Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health.
Hello again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and when it comes to our health, knowledge really is power. And today on Doc Talk, we've got someone in the studio who has made it her life's work to make sure women have exactly that. Dr. Keely Ulmer is a gynecological oncologist at the Cancer Care Institute at Monument Health. She's fellowship trained, a former chief resident at the University of Iowa, and she's a proud member of the Oglala Lakota Sioux Nation, raised right here on the Pine Ridge Reservation. She came back home with world-class training and a real passion for making sure the women in this region get the very best care possible. There's, I don't think, honestly, any better person to talk about women's health right now, what to watch for, and how far treatment has come. Dr. Ulmer, thank you very much for coming back your second time on the podcast, first time in person. Do you remember where you were when you zoomed in that time?
Yeah, I was at my house in Iowa City, Iowa.
Oh, Is that before you came here?
Yep, it was my last year of fellowship.
Excellent. Well, Give me, how did this all begin for you to get you back here then?
Yeah, so kind of a very interesting story, but I went to college to play basketball at Black Hills State University. I was pretty sure that I was going to be a pharmacist. That's what I thought I was going to be. So I was a chemistry major, and then my last year of college, I actually had a little bit of time outside of sports to spend some more time in a pharmacy. And I realized that that wasn't my calling after all. So then I floundered around for a year or so. Some of my professors were like, "You should go to medical school." And, I was like, "Oh, I don't know if I'm smart enough for that." They're like, "Oh, we think you are." So then I worked some odd jobs. I was waiting tables, working at a sale barn, loading out cattle. Applied for nursing school, was actually accepted to go to nursing school, but applied for an Indian Health Service scholarship to fund that. One day, before I went to the sale barn for work, I got a call from Maryland, which is where the IHS scholarship program headquarters is at. And it was actually the boss, the person in charge. It was Captain Dr. Kelly. And she just said, "I can't really sign off on this. I think you should go to medical school. And if you get in, we'll fund you." So I said, "Yeah, all right, I'll give it a shot." Took my MCAT, got some interviews. Now I look back, it's kind of crazy. I got some interviews at some medical schools and then kind of just told myself that if I don't get into the University of South Dakota, I'm not going. Got in, thought I was going to do rural family medicine, fell in love with general OBGYN on my frontier and rural medicine rotation in Winter, South Dakota, which is where my husband is from, and then pursued general OBGYN matched to the University of Iowa Hospital and Clinics for general OBGYN. I didn't have any exposure to gynecologic oncology as a medical student because the gyn onc that was here at that time was in a transition phase, so I never did a rotation. When I got to residency, I realized pretty quickly that I really liked gyn onc specifically. But my husband's a rancher. The plan was 4 years there, come home. I was going to be a rural OBGYN actually in Winter, South Dakota was the plan. So a lot of heart-to-hearts about having to stay for another 3 years. I was a little bit late to the fellowship application. I went into the fellowship director at the University of Iowa. One day, I'll never forget it. I was like, super nervous, but so when you go to fellowship, you have to go through a match process. So you have to apply, and then you have to interview, and then a computer algorithm matches you. University of Iowa very rarely takes anybody outside of the match. And so I pitched to him, like, you know what you're getting with me. I know what I'm getting with you. I want to be very well surgically trained. This is a great program. Why don't you keep me? So they agreed to keep me outside of the match. But I needed to spend one more year because I was late to the application. So I worked for a year as a general OBGYN at the University of Iowa and then continued my fellowship at the University of Iowa for 3 years. So we were there for a total of 8.
You sound like this was all, it just feels like this was in the cards for you. This was going to happen no matter what.
Yeah.
Wherever this path in life was going to take you, this is where it brought you.
When I saw open doors, I took them. Yep, because I figured, if this door swings open for me, it's probably the right choice.
Boy, that's great advice right there. We could just end the podcast right there, being like, look, if that door opens, walk through it because it's great.
Yep, walk through it.
Most people will hear the term gynecological oncologist, and I think in a lot of people's mind, they just think cancer doctor, right?
Correct.
But I want you to help us understand what that actually means day to day. Like, what does your job look like?
Yep. So my job as a gynecologic oncologist is essentially, I take care of female cancers, not breast. Breast really isn't gynonc. That's more breast surgeons. But so uterine cancer or endometrial cancer, vulvar, vaginal, cervical cancer, ovarian cancer, the surgeries, and then the chemotherapy that follows them. I also do complex pelvic surgery, so people with very large uterine fibroids that a general gynecologic provider maybe isn't comfortable with, or suspicious ovarian masses that aren't confirmed to be any sort of cancer, or very large ovarian masses. So just more complex gynecologic procedures that can be benign, but mostly it's those types of cancers, the surgery and then the chemo.
Well, there is obviously, like you said, several different types of these kind of cancers. Can you kind of walk us through the main ones, if there are such a thing, to kind of help us, how each tends to show up and I guess who it affects the most?
Yes. So ovarian cancer, I'll just start kind of with the top
perfect.
3. There's actually 4. So ovarian cancer, the typical age of presentation is later age, so 60s to 70s. Unfortunately, with ovarian cancer, unless you have a genetic defect, there are certain genetic...
I guess I'm surprised by the age for that.
So there are certain patients that are more genetically susceptible to ovarian cancer, like people with a BRCA mutation, for example, BRCA. So those patients tend to have a stronger family history of breast cancer, especially they have about a 70 to 80% chance of developing breast cancer in their lifetime, which is up to age 80. And then depending on BRCA1 or BRCA2, let's say from 15 to 40% chance of developing ovarian cancer, and they tend to develop them earlier. There are prophylactic surgeries to be done in those patient populations, but the vast majority of patients, it's just bad luck. They just, as they have advanced age with many cancers, you're just more likely to get a cancer. Unfortunately for ovarian cancer, there isn't a good screening modality. We've tried, there's not a good blood test. There's ultrasound doesn't work. CT scans don't work. And so the unfortunate truth with ovarian cancer, thankfully it's only about 1 to 2% of the population gets ovarian cancer. But when you're that 1 to 2%, it's 100% for you. So the vast majority of my patients will present at stage 3 or stage 4 because it's hard to screen for. It's a lot of vague or no symptoms until it gets bad. And then those patients, really my job is to decide whether they get surgery up front. Surgery remains a very large, you have to do surgery at some point. It's just whether you're doing surgery up front followed by chemo, or if you're doing a little bit of chemo, surgery in the middle, and then finishing out with chemo. So they tend to be a little bit more advanced stage. But less frequent. However, ovarian cancer, it used to carry the highest mortality of gynecologic cancers just because of the nature of the disease. In recent years, that has shifted more to endometrial cancer. So endometrial cancer incidence is higher as well as mortality. So endometrial cancer, the thing I will say about endometrial cancer, again, there's not good screening. It also tends to affect postmenopausal patients more. There are a few rare patients that, again, there's a few random genetic syndromes that put you more likely to get an endometrial cancer, but they tend to be postmenopausal. The biggest thing to watch for uterine cancer, endometrial cancer, is the more technical term, is postmenopausal bleeding. So you go through menopause, you haven't had a period for over 5 years, or let's say even you're kind of at the age of menopause, but you're still having heavy, irregular uterine bleeding. You really need to get that worked up. So you go through menopause, or you're around menopausal age and you're just still bleeding like crazy, or you develop new onset bleeding. Kind of our saying for that is that's endometrial cancer until proven otherwise. And so you need to be evaluated by a general gynecologist. It requires a biopsy, so an endometrial or uterine biopsy that's done in the office. And then once you get diagnosed, depends, there's, different types. There's lower grade or less aggressive types, and then there's more aggressive types. And surgery also remains a mainstay. So usually a total hysterectomy, we sample some lymph nodes, and then a lot of your your less aggressive type surgery will be all you need, or maybe just a little bit of radiation. But more aggressive types can sometimes need some chemotherapy, or if there's lymph node metastasis. Another common cancer type is vulvar cancer type, so on the skin of your privates. That also tends to affect older age. There's some autoimmune conditions that make you more susceptible to that. The thing to watch for is unrelenting itching, so a lot of itching or pain,
Right.
or a lesion that wasn't there that's starting to hurt, or you're just itching constantly. That's just something that can really make you more susceptible to having a vulvar cancer. That also involves some surgery, some lymph node sampling. Oftentimes you need nothing more than that, but in rare instances, maybe some radiation. And then cervical cancer is something near and dear to my heart, especially in our population here in the northern Midwest, especially among the American Indian population. They have 2 times the incidence and 4 times the mortality of cervical cancer. They tend to present at younger ages and later stages. Cervical cancer is actually one of our best screenable cancers with pap smears and now with self-swab HPV that can triage you into, further workup with directed cervical biopsies or excisional procedures of the cervix. And the big thing with cervical cancer is the earlier you catch it, the better off you are. There are some symptoms with cervical cancer, post-coital bleeding or bleeding after intimacy, intermenstrual spotting. So usually these patients, are having regular periods, but they start spotting between their periods weirdly. And the vast majority of advanced cervical cancer patients really, hands down, are people that are underscreened or never screened. And my last kind of, talking point with cervical cancer is it's really the one cancer that we have opportunity to vaccinate against. HPV vaccine, I know that there's a lot of vaccine hesitancy right now, and it's really been building for many, decades really. And, there's the common myths of this will make, my kids more sexually promiscuous, or, there's a million and one reasons why people don't get an HPV vaccine. And really, HPV vaccine works best when you give it to your kids. So between the ages of 9 and 12, it uses your natural immune system. The immune system at that point is more robust and is more likely to give you long-standing, lifelong immunity to HPV. Not that you won't get HPV, but that your body will recognize that as foreign and be able to clear it.
It is one of our almost best vaccines against a cancer, right?
Yes, and it's cervical cancer, it's vulvar cancer, it's head and neck cancers, which among men, which is one of the fastest growing cancer sites in men. And so all of these head and neck, cervical, vulvar, vaginal are usually largely HPV driven. And I think, the thing is there's a million, an additive or make my kid more sexually promiscuous. But what they don't realize is HPV is ubiquitous across. It's like a cold sore. I often liken it to like a cold sore. So how many people do you know that get a cold sore? Well, almost everybody.
Right.
So almost everybody's also going to have HPV, and this is the one cancer type that we actually have the opportunity to just vaccinate your kids, and then they get to avoid these very awful, harsh diseases later in life. And we just don't have that opportunity in literally any other cancer. So.
It's amazing to me that exists, and it gives you hope too for other cancers.
Correct.
Somewhere down the road, right?
And with widespread HPV vaccine uptake, if we could just get behind it as a nation, as a people, Australia had very, very good vaccine program, and they're on track within the next few years to eradicate cervical cancer among their population. So
that's almost unbelievable.
Yeah, I know, it's great. It happens.
Well, and you covered kind of a little bit of my next question here, is that women's health symptoms can be easy to dismiss, and I think a lot of people are guilty of putting things off.
Correct.
And you listed some of the signs of something that needs. I mean, what are the signs, I guess, of something that needs more than a wait-and-see approach? You specifically listed some for certain cancers. Mm-hmm. Is there anything more generic that kind of elicits a, if that's there, don't wait?
That's a broad question
because
everything's a little bit different.
Right.
For, like I said, with endometrial and cervical cancer, pain, or for cervical cancer, pain, postcoital bleeding, intermenstrual bleeding, or if you just never got screened or underscreened, a very common patient presentation for cervical cancer is, well, when was your last, they present with advanced cervical cancer. Well, when was your last pap smear? Well, with the birth of my last child 15 years ago, because most people get pretty standard screening and care during pregnancies, and then they get busy with life and kids, and then they never get screened. Uterine cancer, again, the postmenopausal bleeding. Anytime you have postmenopausal bleeding or really heavy menopausal transition and bleeding or something like that, that deserves a workup. Don't sit on that. You have postmenopausal bleeding, go get a workup. Get to a general gynecologist, get to a family medicine doctor. You need a transvaginal ultrasound and an endometrial biopsy. Hands down, that one's actually kind of easy. That one's straightforward. Ovarian cancer is vague. Mm-hmm. It's just very vague. I would say there's some pain. In older women, one of the common things is they'll have this bloating or GI dysfunction that's long-standing, not the occasional bloat. We're talking about bloating that just is there and persistent, and then there's some pain, or they notice their belly's getting bigger out of nowhere, unintentional weight gain or weight loss. Those things really need to prompt you to get a workup, to not sit on that forever. And, you can kind of, it's hard with ovarian cancer because it doesn't have a very high incidence. It is more rare. But if those things are going on, you can even think about, all right, you need to have a workup, an ultrasound, and maybe a CT scan. Really honestly, that's the best way. But if you're truly gaining abdominal girth out of nowhere, you might have a mass, you might have a cancer, and that deserves some workup.
Well, let's talk a little bit about something you had mentioned during your introduction, a little bit about something you're passionate about, because I think people know, I think they understand that healthcare access on the Pine Ridge Reservation has historically been underfunded. And as someone who was raised there, what do you see as the biggest gaps when it comes to women's cancer care in that community?
Lack of access, number one. Lack of access, underfunding of the healthcare systems that do exist there, and that's not Pine Ridge. Well, it's really all the reservations here and really nationwide. It's not really a Pine Ridge problem; it's a systems problem.
Yes,
because that money that's allocated for healthcare is woefully low. For example, if you take a patient. Let's just say you take a Medicare patient and you put their healthcare spending as $1. They get $1 of healthcare spending. The VA gets about 0.7 of that $1 that Medicare does, and IHS gets about 0.4. So it's grossly underfunded, which leads to so many systemic problems of staffing, of high staff turnover, the problem of what time of year referrals happen, just because it's allocated as a lump sum. So there's just so many, I could go on and on. There's just so many systemic problems, lack of specialty care. I'm trying to write that. Hopefully in the works here soon, I'll have an outreach clinic close to where I grew up.
Yeah.
So I'm hoping to decrease a little bit of that disparity, especially for patients. It's not that, and then there's travel and there's socioeconomic. There's just so many long-standing issues that really came from years of forced colonization and, so many systemic governmental issues that I think really truly affect patients. And so I'm hoping to be able to at least decrease some of that burden and help with some access to care, both through my own clinic in partnership with IHS and then the Walking Forward program, which I know that you guys have talked about before.
Well, explain that a little bit again, because this was a podcast that was a while ago. It's fresh to bring it back up again.
So Walking Forward program is a long-standing, over 20 years NIH, National Institute of Health funded program that Dr. Peter Wright, who's also been a guest on this show, a radiation oncologist here in Rapid City, started about over 20 years ago. And the major goal of Walking Forward is screenable cancer. So he's done a lot of work in the prostate, colon, and lung cancer screening space. I was hooked up with Dan when they were interviewing me for the job here. So part of the reason I came back is I was always going to come back. I feel very passionately about increasing the access to care among my people and among, American Indians throughout South Dakota, just everybody. It's not even that. It's rural. You know what I mean? Like just rural patients who all experience a lot of the same levels of disparity compared to non-rural or more affluent. And so I was put in touch with Dr. Peter Wright when I was interviewing about 3 years ago. And ultimately, he viewed me as a good person to bring into the fold and eventually take over the program when he nears the age of retirement. And so right now what I'm trying to do is expand that screenable cancer cohort into cervical cancer, which is a huge problem, as we've talked about. He has the Walking Forward program. I guess we now have a very robust patient navigation system, which is that's been proven time and time again to be invaluable to patients getting the next level of care. It's not just about the screen; it's about the follow-up to the screen and helping patients navigate that process. I mean, the big city is scary, like getting to the big city, getting to the hospital. Where do I go? Like all of that, and the patient navigation helps a lot with that. So that's what I'm trying to, again, increase access for cervical cancer care, follow up with patient navigators, and then hopefully be able to get my own subspecialty clinic going on the reservation, and with, the hopes of expanding that to many other rural communities, not just on the reservation, but, in different places that need that access. I need to get a partner to do that, but I'm working on it.
Well, if anybody out there wants to help, here we go.
Yeah.
Well, and I think that also will go a long way to the people that are still living on the reservations too. That's their life. But that all of a sudden that kind of little ray of sunshine pops up there, like, hey, wait a minute, I can get help here. I don't have to go all the way to Rapid City. Right?
Well, and I think it would help even the providers that are providing access to care. That takes a level of complexity off of getting the referral out, getting people there when they know, okay, well, there is this specific subspecialist that's coming out once a month. Like, so much easier to send them to me there than it is to coordinate it. So I think it would, that ray of sunshine, and also just ease, to meet patients where they're at instead of the other way around.
Well, and that alone makes such a huge difference.
It does.
Well, if you could say one thing, doctor, to a woman who is kind of scared right now, maybe sitting with a diagnosis or waiting on results, what would you want them to hear?
I would want them to hear that, we've come so far in our treatment of gynecologic cancer specifically that this is not hopeless. Even with advanced stage ovarian cancer, they're very responsive to chemo. Around 80 to 90% will respond to chemo. It's not a death sentence anymore. May it shorten your life? Yes, but we're not talking about, we're talking about adding 5, 10 plus years to your life with treatment. So, even with some of the worst diagnosis, we've come so far in our treatment algorithms, surgical technique, targeted therapies, things like that. So even, after the upfront treatment, there's still many, many options if you are to recur to target your specific tumor profile, your genetic profile, things like that. We've come so far in the science that it's not really hopeless. And endometrial cancers, some of those other cancers, endometrial, vulvar, big thing is like get on it early. And, there's a good chance that you're going to die of old age with one of those other things, and so it's not hopeless, and it's not a death sentence. It's it's a new chapter, but it's not the end of the book.
Well, that's a great way to put it. And, obviously, anytime you hear the word cancer, no matter what it is, it's always scary every single time.
Yes.
Well, Dr. Keely Ulmer, thank you very much for coming in and doing this. This was great.
Yeah.
And anytime you want to come back and anytime you want to talk about anything else that you just feel really passionate about, I would love to have you back on the podcast. All right.
Thank you.
Dr. Keely Ulmer is a gynecological oncologist at the Cancer Care Institutes at Monument Health here in Rapid City. Thanks for talking with me, Doctor.
Of course. Thanks for having me.